Good evening, good morning, depending on which part of the world you are in. Welcome to another edition of Intellectual Calisthenics. Today, I have the honor and privilege once again to have Dr. Mishra, Dr. K Mishra with me today. Thank you, Dr. Mishra, for investing your time to enlighten all of us. So the topic that we are going to discuss today is how do you assess a thyroid nodule? And Dr. Mishra, if you've been watching to the audience, if you've been watching our previous episodes, you know that Dr. Mishra wears several hats. So today he's here as the professor and head of the Department of Surgical Endocrinology at the SGPGI Institute in Lucknow. So that's a very prestigious academic institute in India. And the other hat that Dr. Mishra wears, and on which we have a video as well, is as a telehealth. He's been one of the pioneers of telehealth in India. So, welcome, Dr. Mishra, and please will you say a few words about your journey in surgical endocrinology, because you're one of the pioneers in that as well.
Yeah, surgical endocrinology is a very new branch, you can say, in India. We started here when I joined here about 31 years ago. I was trained as a general surgeon with a special interest in endocrine surgery at PGI Chandigarh. So from there, I came to this place in 1989. Exactly, I joined in September 7th of 1989. So this institute was originally planned as a super specialty institute, right? So that's the reason why the endocrine surgery department was started as a super specialty branch of surgery. There are no other academic department started that time. Of course, after that, in 31 years, we have trained many people and we started our
Hello.
program, which is at 3 years. And all our alumni, around 45 or so, they have gone to different parts of the India. And I think almost now two-thirds of India is covered now out with our alumni. And they are either
Hello, Dr.
corporate
Mishra.
practice or they're already academic institution. And there are 4 departments of endocrine. So it is a upcoming specialty. I'm sure in a couple of more years, you'll find it will be reckoned with, recognized as a distinct super specialty of surgery. Because the disease load is now coming up. People have realized there is a need for an expert surgeon to handle the problems of the endocrine glands. The general awareness about endocrine glands is particularly
Yes.
thyroid. And besides that, breast surgery is also now considered part and parcel of endocrine surgery because many of these hormones, especially the estrogen, progesterone, are influencing breast cancer.
Mm-hmm.
And third thing is the thyroid and the breast, both are common in women. And another gland called parathyroid, that is also common in women. So whether it is good or bad, God has been very unkind to the women, also to give them additional disease burden. So that's why this specialty has a bright future. Then the endocrinologists also prefer endocrine surgeons to take care of the diabetic foot problems.
Mm-hmm.
Diabetic foot usually are complications of diabetes, and they want endocrine surgeon to be around so that they understand each other, so the foot management better. So that's the introduction about my department, and I can say that we need specialist endocrine surgeon to take care of endocrine problems, needing surgery.
I hope and wish we have a lot of young upcoming surgeons in our audience. And Dr. Mishra, this is very interesting. I did not know that breast was also considered to be in the endocrine surgeon's area, because we used to think of the breast as more an oncosurgeons. And of course, there are some oncosurgeons who specialized in the breast. But from the breast, we are going to go off to so I'm going to start sharing the PowerPoint to assessment of a thyroid nodule. And can you see my screen? So you can just tell me next slide when you are ready, and we will do that accordingly. Let me just go to the slideshow.
Yeah.
Sorry, a bit of confusion here. Okay, so here we are. I'm going to minimize this one. So Dr. Mishra, the thing is a little bit of background about thyroid nodules, because I am a specialist in functional medicine and I live in Alberta in Canada. And my medical practice is mostly in India because that is where my medical license is valid. And so what happens, this was my challenge. The reason I reached out to you about thyroid nodules was because I cannot do a physical examination in the patient. And as you know, many of these thyroid nodules are not always visible if I'm seeing a patient on video. And Hashimoto's, that is autoimmune hypothyroidism, is extremely common in India. So routinely, I recommend a ultrasound of the thyroid because I don't have the luxury of having someone actually do the thyroid, the neck examination. And as a result, of course, if we go looking for something, we will find. And I would find, patients would come back with an ultrasound report of a thyroid nodule. And again, because my patients are in different cities in India, and as you know, it's not the same everywhere. I don't always have the luxury of referring them to a endocrine surgeon. So I would suggest, okay, you need to go to your endocrinologist because you need a biopsy very likely. And then of course the whole journey starts. So from that, again, the other question I had, Dr. Mishra, is you are in a specialized center. How do most of the thyroid nodule detection, how do they come to you when they are like, usually is it referral, or because I know you don't see primary care patients, right?
No, we don't. We
So
don't see primary care. We
yeah.
say get always referral thing. So let me address your question in two or three parts. See, but thyroid is a gland which is the domain of many caregivers actually.
Mm-hmm.
So as I told you, because this is mostly common in the women, and so patients don't go to the endocrinologist to start with actually. They
No.
will be going to either a internal medicine person or general practitioners, a family physician, or they go to when they're going to go to gynecologist, they may find, oh, what is their neck, just like that. So the commonly diagnosed condition is accidental. Let me tell you, put that
Mhm.
accidental. That is one way, and because it's the neck, so it can be noticed. So it can be noticed by the family members. It can be noticed by the patient herself or himself, because standing in the mirror, or somebody looking at the colleagues in the office or wherever, friends, or if they're going for a medical checkup for other conditions, then thyroid examination is part of a general physical examination.
Thank you, Dr. Mishra. Somehow
That
your
is
audio.
examination in
Sorry,
a undergraduate class.
Dr.
Thyroid is.
Mishra, I am
Can
sorry.
you hear me?
Will you please repeat the last sentences? Something happened to the audio.
Yeah, what I meant to say is the thyroid is a gland which is being taken care of by so many caregivers,
Mm-hmm.
starting from the nurse to doctors to colleagues, whatever, you can say, well wishers. So this is a gland which is located in the neck in the front, so it can be detected by the patient themselves or anybody who is coming in contact with the patient. So that is the thyroid nodule. The other way of detection is this examination of the thyroid or neck. Let me put it that way, neck examination.
Mm-hmm.
Then they can find out the thyroid also, because it is not seen.
Mm-hmm.
But as routine examination, you have gone for some other problems, but thyroid is also examined as a routine examination, a
Yeah.
clinical examination, like pulse, blood pressure, examine the neck, thyroid. So somebody will just put a hand, and thyroid being superficial, one can detect very small nodules also. Even 1 centimeter nodule also can be picked up, which patient might not have noticed also, right?
Mm-hmm.
The third way of detecting is when if somebody is doing a PET scan or ultrasound examination of the neck for other regions, then also the thyroid is nodule is picked up. So that is the non-palpable thyroid nodule. They also pick up. And for example, head and neck cancers, when they're treating for radiotherapy, sometimes the PET scan, they also see a PET detected thyroid nodule, because PET is responsible for detecting so many hidden kind of conditions in different parts of the body. So there are different ways of getting the thyroid exam and thyroid problems detected. Then, of course, it can manifest with some conditions indirectly because of the metabolic problems that you have yourself practicing that. Somebody may be going to doctor for suspected hypothyroidism because one lady complaining something like a little bit of not energy or feeling
Mhm.
hypo, or this is a very common word for hypo. I'm hypo means I'm not feeling well. Hypo. Yeah? So the hypo is synonymous with hypothyroid. Somebody adding some weight, especially nowadays in the urban population, not rural population. Urban population are very careful about their weight, and they're very careful about their alertness, their intelligence, their psychosocial status. Naturally, with the high society things in their uh, free time, they talk or games they play, there's something like that. Then they talk of this thing. Oh, you have this thing. Oh, I also have the same thing. So please go and get checked. So nowadays, even the detection of the hormone status and also therapeutic. Let me tell you, thyroxine treatment is one of the most abusive treatment that is
Yeah.
being seen, like antibiotic abuse. So thyroxine also being abused like anything.
Mhm.
So in this, really,
That is
uh,
the unfortunate part. So
but
hypothyroidism, again, Dr. Mishra, just a little
I'll
bit
talk
for
about that. I'll
audience.
talk about that. Yeah,
Yeah,
sure.
the symptoms are so they are not non-specific. For example, someone with iron deficiency anemia would also could feel fatigue. So a lot of different areas. Now, just a little bit about thyroid function tests. In traditional medicine, most doctors test for a TSH, T3, T4, maybe free T3, free T4. In functional medicine, we always make it a point to test for thyroid antibodies. And again, I'm not going into that today because we're going to talk about evaluation of the nodule. So when you talked about the quadruple assessment in thyroid, so what is the functional assessment of a thyroid nodule?
See, usually you go for a triple test, usually, and maximum hormone you do is a TSH. If you find a thyroid nodule, the first test in hormone do a TSH,
Mm-hmm.
because that will decide whether the thyroid is functioning okay or thyroid is functioning hyper, right? If thyroid is functioning less, then definitely the TSH will show high level. So the minimum test hormone you do is the TSH. We never do all those battery of T3, free T3, free T4, like chain of things with antibodies. Now, many of these commercially launched labs, they
Mm-hmm.
always kind of recommend this kind. They encourage people to do all these things. They advertise in the newspaper. So as I told you, you don't require a prescription to get yourself tested. You can just go to
Yeah.
anybody, get a prescription, something like that, get tested. But what is the unfortunate thing is, if you see those reports coming out from those laboratories, they not only have this report. I don't have any problem with their report. It's fine. They're accurate. They're counted by NABH, like Indian laboratory standards. They're controlled by that. I have no doubt about their accuracy. But what disturbs me is the comment they give. They also give, if it is this, then this is that, this is that. Then that makes the again patient confused, just like they go to Google and they get confused. So that is another part. So I think we should educate our patients that just only TSH is enough. We'll decide next what next hormone should do it. That's one thing. But
So
however you tell them not a car, however you convince them, still they'll come with all full report.
so, Dr. Mishra, that is one area where I will beg to differ because in functional medicine we do a complete assessment of all the hormones. But anyway, that is a different conversation. And the fact that you mentioned about the comments on the report later on at the end when we talk about thyroglobulin, that one will come up. So this is the next slide I have, and Dr. Mishra, will you explain a little bit?
Yeah. So what I actually not answered your question is how to assessment, because we stuck in the hormone estimation part. So the minimum thing that you do is a clinical examination. That is very important actually. We must examine the thyroid. It's not that difficult organ to feel. Please feel the extent of the thyroid. If you find a nodule, then find the characteristics of nodule, whether it's smooth nodule, whether it's irregular nodule, what is the consistency of this nodule, and what is the relations of this nodule with other parts of the neck. For example, you have a thyroid nodule, then you have a lymph node also in the lateral compartment, then definitely it has a different connotation than only having a thyroid nodule. How big it is, right? And all these things are very important. Where it is located, whether it is one lobe or it is the other lobe, whether it is bilateral, whether it is also located in the isthmus. So all these things are very relevant. So that is the information you get from clinical examination. And second thing is the radiology. That is also very important. Today, ultrasound is part and parcel of any clinical examination. Every physician has ultrasound along with their other armamentarium. It is no more considered as a radiological domain. Let me tell you frankly, every physician also has an ultrasound. It's just like a cardiologist having a stethoscope, or a physician having stethoscope. So ultrasound is an extension of clinical examination. Why? Because that will help the clinician to decide what is the next line of management, next line of investigation, how it is to do, and some impression the physician will get out of it. I'll show you some of the pictures, how it is important for a physician also to understand. And nowadays, with so many other adjuncts coming to the ultrasound findings, it will be helpful for the physician to take the next course of action. And next course of action is the cytology. This minimum three things one has to do. And quadruple, I said, functional, which also can become a part and parcel of this thing. And there are guidelines laid down by, different societies give guidelines. We always follow the American Thyroid Association guidelines. It's called ATA guidelines. And whatever I've told you regarding hormonal assessment in thyroid nodule is based on the ATA guidelines. So all this assessment will give you some idea after these reports are available, give some idea what kind of nodule you are dealing with. So if you go to next slide, you'll find some information is there.
So,
Yeah.
Dr. Mishra, before we go on to the next slide, this is a question from your, telehealth experience, because given the COVID pandemic, telehealth has got a big boost. So one of the challenges that we always face is how do we do a proper physical examination on telehealth? Some specialties are, they find it a big challenge, like neurology. And you talked about assessing the thyroid nodule. So on one hand, like I talked about my challenge, I cannot do a physical exam. So I recommend an ultrasound of the thyroid. So that is a very fine line, if I understand correctly. And in your expert opinion, Dr. Mishra, because see, traditionally, ultrasound of the thyroid is not really a part of a thyroid assessment when a patient goes to get checked for hypothyroidism. And when we do more tests, the risk is always there that we'll find more problems, and some of those problems may not even need treatment. So how would you recommend to someone, let us say someone like me or someone, in the sort of more like a family care or in internal medicine, person, what would be sort of your best practice recommendation? Because since I can't do a physical exam, am I justified in recommending a thyroid ultrasound for every patient? But given that I have to explain to the patient that we might find things that, that may not be very significant, how would you say someone like me could make that decision? Like, where should we recommend an ultrasound? Should we routinely recommend an ultrasound? Or should we, because of the challenge of not being able to do a physical examination?
Uh, Very nice observation you made it. Let me tell you what I used to practice actually. So let me tell you, any thyroid nodule less than 1 centimeter has no significance, right? Very rarely one will be tumor, and we're not by not diagnosing that cancer in that 1 centimeter nodule is not going to really make much big loss about that. Very rarely you'll find tumors of that size, less than 1 centimeter. Why I'm telling 1 centimeter? Because the clinical observation through a camera, you can detect a thyroid nodule of 1 centimeter unless the patient is very obese or thick neck or short neck. So usually what I do in my practice, I always look at the patient's neck, extend it, and ask the patient to swallow, taking little water side, right? So even people have taken their selfie and sent it to me, I am able to diagnose, right? And I tell them also to take a glass of water and take a selfie, and they have sent it to me, and it's very easy to do. Number one.
Yes.
Number two, what also we do it another way around is that we always call them to we have a teleclinic in one of the remote locations where we do practice actually. This what I told you is the WhatsApp method. Other thing is they come to a clinic, and we have a teleclinic going on for last more than 20 years. They come there and there is a technician, and the technician they train how to do it, and they just fill that, and there's a nurse also, and there's a doctor also there. They can also feel it and tell that there's a nodule there. But what is more important is it is just an
Sorry, Dr. Mishra.
after you find there's a nodule, what I want to know is whether a single nodule or multiple nodule, whether a single nodule or a multiple nodule, or it is diffuse kind of gland enlargement, because you can find a diffuse enlargement thyroid also. You can find a multiple nodule also by the camera, right? Take a zoom camera. So it will ordinary camera also, you can zoom it and find it, PTZ cameras. So that is very good in that. And after that, when the ultrasound is done, then let this ultrasoundologist send you the video of the ultrasound, so that in video you'll find the exact sequence of events and multiple cuts in that. Or if video is not there, they can take a thermal painter, take snapshots and send you, right? So that's another way of doing it. And of course, there are many advancements that occurred on tele ultrasound. So it is just like a pocket ultrasound. You put in a mobile phone, and I'm sure you must have available in Canada also. One 7.5 megahertz or 10 megahertz probe, single probe, put in the neck and put it in the camera and send it to video. You can see a continuous video coming to your place. So all these technological gadgets are available now. It depends on you how you can do it. Very pretty, accurate. You can find
Wow.
images.
Dr. Mishra, I'm going to start using your selfie idea now. Make the patient swallow and take a selfie. Because the other thing is I can add it to my patient chart as well to remind them also.
Yes,
Yeah,
you can
that's
document that. No, it's better.
that is very simple idea and very significant, definitely. And so the next this is the slide that will you expand a little bit on this one?
Yeah, this is basically I put in all the pathologies that you get in the thyroid.
Yes, Dr. Mishra,
And
the
you don't
audio.
find any nodules anywhere, and it's not tender. Audio problem? Okay.
Yeah, audio was a little bit
So,
on. So these nodules that you're
okay.
talking about, solitary nodule, multinodular goiter, these are all on palpation, right?
Yeah, these are on palpation, or also you can ultrasound also. In ultrasound also you'll find maybe one nodule is bigger size, but there are smaller nodules in other lobes also.
Okay.
So all depends. Then your final diagnosis on clinical impression depends on ultrasound, not only a clinical examination, right? Because you do not know there are small
Yes.
nodules on the other side also. Sometimes you cannot feel the nodules, but there are also nodules by ultrasound wise, right? So ultrasound is more accurate as far as picking up the nodules in the other lobe, and finally telling whether it is a solitary nodule or is a multiple nodule in the.
Okay.
Then there are diffuse goiters, like in if I have Hashimoto thyroiditis, or it is a diffuse goiter because of iodine deficiency. So diffuse goiter without a nodule, that also you can find it. And of course, you can find asymmetrical enlargement. One is bigger, one is smaller. All kinds of permutation combination can be there. But besides nodule, you can characterize the nodule. In the sense, the nodule is irregular and it is kind of invading somewhere and all these things. So those are all very characteristics of malignancy. So that also you can find. So what I say, dominant nodule, that means there's a big nodule one, and there are smaller nodules. So make a dominant nodule. Sometimes what happens in secondary hyperfunction, like you call the toxic multinodular goiter, then one of these nodule becomes hyperfunctioning, right? So called dominant nodule. So that is secreting maximum number of hormone. You also give Graves' disease where there is diffuse goiter. Both lobes are enlarged, and because of hyperfunctioning. Sometimes you find Graves' disease along with nodule also. So you cannot stop a nodule to come up even if somebody has a Graves' disease, because both have different etiology, right?
Yeah.
These are different characteristics of a disease pathology of the thyroid.
So this is okay. I think you've already talked about this, because solitary nodule less than 1 centimeter is risk of malignancy is very low. That is what.
Very negligible. Very
Yes.
negligible.
And another quick question, Dr. Mishra, is see, lot of ultrasonography, clinics, sonologists, if they don't have a lot of experience doing thyroid ultrasound, would you say that that would make a difference in the diagnosis of how they assess the thyroid? Or is it like it doesn't, like any regular sonologist who does all kinds of ultrasound can usually do this? Do they need some special
So
training?
yeah, I have put a slide here, and subsequently will come in one or two slide chapter. It's called TIRAD. In TIRAD, so they just have to give them parameters. So that's called thyroid imaging.
Yes,
Like
so
in BioRad.
we'll come to that.
Yeah, gone to that. So what you need the ultrasonologist to just give a thyroid report. That is a structured report. It is just like mirror for breast ultrasound. So this has really helped the endocrinologist or the surgeons to take interpretation that he is going to deal with a benign goiter or is a malignant nodule, because depending on those thyroid criteria, so we can suspect which more malignant or benign. So it doesn't matter whether that ultrasonologist is very experienced or not experienced, right?
Okay.
So, yeah, unlike parathyroid, in parathyroid you require
Oh,
experience.
yes. We talked about that. The experience is very important.
Yeah.
So,
And yeah, another thing also, the question also to be answered is sometimes what happens is the nodule malignant?
mhm.
See, to some extent, the ultrasonologist, if he experienced ultrasound, can tell about that this is irregular and there is a solid mass inside a cystic lesion.
Yes.
And I'll show you some of
You
those
have, yeah,
criteria of
you
the
have some
TIRADS.
very beautiful
Yeah,
images.
yeah,
So we'll come to that.
yeah.
And
For that.
this is Dr. Mishra, this is very, what you brought up is very important about the reporting. So what I have started doing is, I think the ATA had some, thyroid specific, ultrasound specific guidelines, like the length versus the height and all those things. So nowadays I usually
Yes.
give a handout to the patient because they go to different ultrasound clinics and not everyone is a specialist in this. So I think, is there like a handout that we could send to every patient that this is the ultrasound we need to look for, so that the report is sort of standard? Because it's, as you rightly pointed out, the report is not standard everywhere. It's like they don't report the same way.
Exactly. You have answered yourself actually. So it is very important that we ask the radiologist, please give me your report in this. See, it is recommended. They also, many centers they give, like Birad, now everybody gives Birad report. Birad 3, Birad 4, Birad 3, like that. So
Mhm.
here, the Thyroid came after Birad. So
Mhm.
now people are picking up. And if we insist, definitely they should give it.
Mhm.
And once they give it, then it becomes standardized and it helps for remote physicians, especially for remotely practicing.
Yes.
Then it helps you out take interpretation of that.
So, Dr. Mishra, will you just explain what is a toxic nodule for people maybe who don't know what a toxic nodule is?
Yeah.
Now, retrosternal is behind the breastbone and that is not a nodule which can be felt on examination, but it can be seen on ultrasound. Is that easily visible, the retrosternal nodule?
No, actually,
Hello, Dr. Mishra, your audio is.
no.
Sorry, Dr. Mishra, will you please repeat that? The audio went off. The retrosternal
Okay,
nodule,
so
how would one detect that?
I understand that. One is the nodule in the neck can
Mhm.
extend behind the sternum. Can you hear me?
Yes, I can hear you now.
Can you hear me?
Yes, I can hear you.
Oh, so the retrosternal nodule, one is the big nodule in the neck which is extending behind the sternum,
Mhm.
right? So partly in the neck, partly in the retrosternal, right? Second is you may not find anything in the neck. There
Mhm.
is retrosternal. It's behind the sternum.
Okay.
But in that case, you will not find by ultrasound. Ultrasound cannot detect retrosternal thing, only pure retrosternal. If it
Yes.
is behind the sternum completely or thoracic,
Mhm.
ultrasound cannot detect that. Yes, you cannot.
So how would
Only
they
CT
detect
scan can
that?
detect that. But
Yes.
however,
Okay.
how they will that, because if you are suspect, sometimes what happen, this pure retrosternal goiters,
Mm-hmm.
nothing is in the neck. Of course, very rare.
Very
Usually, what we found is 90% cases it is in the neck. They extend to the chest,
extended.
right? Even 90% in the chest, 10% also you can pick up in the neck. You tell them to swallow, they'll find it's coming up, plunging type. But
Mhm.
one is totally pure 100% retrosternal, or entire goiter has been retrosternal. Then most of these cases are detected because the patient is having some respiratory problem. They go to
Okay.
the physician, they do a chest X-ray, then you find a mass there. So
Mhm.
that's the way of detecting those retrosternal nodules
Mhm.
by a thoracic mass because of symptoms not related to this. Someone may have asthmatic problems and
Okay.
they go for chest X-ray, they'll pick up those things
Mhm.
accidentally. It happens such a situation.
That's
But
very
what is toxic nodule? Toxic nodule is when the patient has the toxic symptoms, and this can be of two types. One is the primary, or it can be secondary. The
Mhm.
primary is solitary thyroid nodule, which can become autonomous, right? It will become autonomous and start secreting higher level of hormones. So it becomes solitary toxic thyroid nodule, right?
Mhm.
Which can be picked up by ultrasound. But to diagnose 100%, you have to go for a radioisotope scan,
Mhm.
which will show that this is a hot nodule. The rest of the thyroid are not taking anything. That's the only condition where you pick up by isotope scan. Otherwise, isotope scan is no more needed nowadays for routine assessment of the thyroid nodule. Other thing is toxic nodular goiter. When there are multiple nodules in the gland, mostly it occurs in the secondary situation. We call it secondary toxic goiters. That is the primary one. And here, the one of the nodule become autonomous. We call it dominant nodule. So they secrete lot of hormone. So there you will find, if you do a sit-up scan, you will find one of the nodule uh, is hot, other things are not hot. You get a patchy uptake of the gland.
So, Dr. Mishra, a toxic nodule would definitely show abnormalities in thyroid hormone levels. So, it is very unlikely that it will not be suspected, right?
No, it cannot be. It cannot be suspected. Because there is toxic symptoms.
Yes.
You do a hormone study, you'll find the hormones are deranged. Then you diagnose this is a toxic goiter. Then
Yes.
you look at the gland. So it can have a Graves' disease, that is the diffuse goiter, which involves bilateral disease, or it can be also due to solitary thyroid nodule, again the primary. And third is a toxic nodular goiter, which is bilateral disease, but one thing is dominant actually. There is a fourth condition, which is very rare. It's called hashitoxicosis. Sometimes some of the Hashimoto's thyroiditis also can manifest with the toxic. We call it hashitoxicosis.
So usually, so basically what I want to point out is a lot of people, if they're not regularly doing this, very unlikely that a toxic nodule will be missed if you are routinely checking thyroid hormones and you're seeing the patient, because the symptoms will be there, racing heart rate, a lot of different, and patient may already be on medication also. So it's very unlikely that a toxic nodule will be missed. That is my point. Because one of the concerns of most clinicians is, am I missing a cancer? Am I missing something that is very serious? These are some of the major concerns that most of us have. So what would be the
So
difference?
I just want to,
Yes.
Dr. I just want to finish that slide actually. So let me tell you one thing. Majority of toxic, say in medicine we cannot be very dogmatic, but majority of toxic goiters are not malignant, they're benign, right? Very, very rarely you'll find malignant toxic goiters, but most of the toxic goiters are benign in nature, whether it is primary or secondary. You can move to next.
Thank you. So the differential diagnosis of solitary nodules and multinodular goiter, just will you explain a little bit about these?
Yeah, so as I told you that, a solitary nodule is very common. That's a very common way of manifestation of thyroid pathology is a nodule, single nodule. So this nodule, if we investigate further and do also the cytology examination, ultrasound, etc., then you can really reach a diagnosis that is a non-toxic nodule, and it can be our three types, either it's a hyperplastic nodule, or it can be adenoma, simple adenoma, follicular adenoma, we call it follicular neoplasm, and another is the carcinoma. So these things will be distinguished by the aspiration cytology, right? And very uncommon are cyst, just true cyst, only nothing else. I'll show you some ultrasound about that, true cyst, and focal thyroiditis.
Okay.
So focal thyroiditis give a solitary nodule and along with the thyroiditis manifestation. Otherwise, most of the cases thyroiditis are diffuse phenomenon. These are the common conditions, solitary nodule, and mostly are benign. Very rarely it can be carcinomatous, right? So cytology is the clear piece. Very rarely, some of the cases you may not be able to distinguish between benign and malignant conditions. So there are situations where you need to excise the gland to have a final diagnosis. And in the multinodular goiter, most of the cases are diffuse nodal hyperplasia. Again, if there is apprehension about the patient, about the cancer, please explain them that the majority of the cases are benign in nature. This can be diffuse nodal hyperplasia due to several reasons. Most common thing is the iodine deficiency. Wherever there is iodine deficiency is there. And diffuse thyroiditis comes next in the line in terms of occurrence, because it's quite common in the women, especially in the after first pregnancies. Usually they develop this autoimmune thyroiditis. There are different types of autoimmune thyroiditis. Hashimoto's is one of the common thing. So that is going to be a chronic condition. They never become cured. So you have to watch them. And the ultimate natural history is they develop hypothyroidism and you have to treat them actually. And rarely there can be carcinoma, and that can only be diagnosed by aspiration cytology. So depending on the situation you aspirate, and you can find the final pathology.
So, Dr. Mishra, later on I'll come to, are there any specific symptoms of thyroid carcinoma that patients can find? I think we'll come to that later when we talk about the clinical applications. This is what you talked about, and this is very interesting. The ultrasound machine to the endocrinologist evaluating a thyroid nodule is analogous to the stethoscope of the cardiologist. Yes. And as you mentioned, nowadays small ones have come up, so it's like it's something you can carry in your bag, right?
Yes.
And do those, so Dr. Mishra, are those very expensive, those tiny, small ones with a tiny, like, probe?
So actually, I have not purchased it. It's available. Even it's available in US market about 10 years ago. But now
Mm-hmm.
it must be available in Canada also. You can have a look at it. It may not be very expensive because it will fit into your mobile phone, and
Mm-hmm.
you just buy a probe.
Yeah.
You just look for it. Amazon also you can get it, or in a medical equipment company you can ask for it.
Okay.
It's available now in the market actually.
Yeah, that's
Unfortunately,
what I.
In India we cannot use it. There is a law forbidding us to handle ultrasound. It's only the authorized people they can handle
Oh,
radiology
I
and
I didn't know that because I was an obstetrician gynecologist before. So obstetricians, oh, I think they need a special permission because of.
no, no, no. The obstetrician are allowed, cardiologists are allowed, radiologists are allowed. Not any other, no other category of
Oh,
physicians are
that
allowed.
that is interesting. I didn't know that.
Something called PNDT Act. So they will
Yeah,
be
that
arrested and
yeah, yes, that applies to obstetricians more than anyone else. So this is a somewhat busy slide, but Dr. Mishra, you're going to summarize it for people. What are the suspicious ultrasound features?
yeah, that's why I've made these
Yes.
blocks in the red actually. So you don't have to see all other, don't forget about other parameters. So this is basically to highlight that
Dr. Mishra, the audio is gone. So while I wait for Dr. Mishra's audio to come back.
are macrocalcifications and
Mhm.
taller than wide, right?
Yes,
Taller
taller
than
than.
wide.
Mhm.
I think I'll use the headphones. It's a little problem, I think, in getting the voice.
Okay. So basically, I'm just repeating what you said. One is solid. The next is mixed hypoechogenicity. So hypoechogenicity is what is detected on ultrasound. Then is it irregular margins, right? Uh,
Yes. Is it
Irregular
better? My audio
margins.
is better?
Yes, this is
Is my
better.
audio better now? Okay, okay.
Yes, I think it's a problem of the internet connection, not your personal audio. Microcalcification and taller than wide. So basically, these are the ultrasound features uh, that are suspicious of cancer. Obviously, no cancer diagnosis is confirmed unless a cytology or a biopsy is done. So, shall I move to the next slide, Dr. Mishra?
This is why I'm telling you, it's not that 100% all these features are suggestive of carcinoma, but one will make suspicious
Mhm.
and go for a cytology of this patient definitely. Okay, next you can move.
Okay,
Now
so.
these are the couple of ultrasound features I like to tell you, and any common persons also, even general physician also can do ultrasound also. And
Mhm.
because as I told you, thyroid is sought after by so many caregivers. Now ENT surgeons are coming, obstetricians are doing, general physicians are doing, or endocrinologists are doing. So what I mean to say is, if a cystic nodule, you are fairly safe, and this type of features you can get it remotely also. Even Canada also, you can find out this coming to you. Snapshots will come up, and you can honeycomb spongiform pattern. Again, it is also mostly in benign nodules. What
Mhm.
to make you suspicious is go to next slide. So you'll find this kind of thing. So this is also benign, but one has to be very careful. Sometimes you find intracystic carcinoma.
Mhm.
So you have to be little careful on such kind of thing, because when you aspirate,
Mhm.
obviously cyst you aspirate, nothing will come out. It will come out a colored nodule
Yeah.
actually. So nothing will come out on cyst. But this kind of phenomenon where majority is cyst but there is a solid component, then one has to do ultrasound guided aspiration. That's
Yes,
very
I
important.
was I was going to come to that, whether people should look at
Yes.
just a without ultrasound FNAC,
Yeah.
or should it be
Right.
recommended to do an ultrasound guided? So I think we'll
Yeah.
after we finish these, I'd like you to
Yeah,
talk.
so the, like the suspicious as a thyroid nodule, also the length and breadth that you have talked about. So
Mhm.
all these things are there. So in the same sitting, the ultrasonologist should be competent enough to do a ultrasound guided biopsy also. It's not that I do ultrasound and send it to somebody else to do a
Yes.
ultrasound guided biopsy. Okay. For example, you are doing in your clinic in the outpatient office, it is fine. Or you picked up
Mhm.
something and you become suspicious, and then you send it to a ultrasound. Somebody can do a interventional procedure. That is fine. Obviously, you cannot do intervention in the office. Already you are
No.
equipped to that, or you have been permitted to do that. So you should, for that reason, so you have to be very careful to picking up cases which need a ultrasound guided aspiration. Not that all patient deserves ultrasound guided aspiration, right?
Okay. So these are.
These are definitely very very suspicious. Starry eye, you can say the starry the sky full of stars. We
Mhm.
call it starry phenomenon. So stars like stars, and like comets, you can find some tail of these stars. Then macro calcification. This is definitely very very suspicious. So such kind of thing also. That's why I'm telling you how ultrasound has really added to our accurateness of picking up cancers at early stage. Even small tumors also are picked up with these things. So, because the next slide also Doppler you added, and then Doppler. So
Mhm.
Doppler also gives an indications that it is going to become a malignant in nature, because they are more vascular tumors actually.
More
So
vascular. Okay.
more vascular. So only thing that you can say this kind of phenomenon is toxic nodular goiter. So
Mhm.
there also you can get a vasculate like the other. It suggests a malignancy actually. So there's a nodule here, and there is a put the Doppler, and you find the this is
Mhm.
a nodule and Doppler. You find the vascularity. So the equipment should have facility for Doppler,
Doppler.
and same thing. You can just put the switch for Doppler, and same time you can assess. So without Doppler, your assessment is not complete in ultrasound
Okay.
assessment.
So I was going to come to that. Is there specific ultrasound machine requirements that would be ideal? I know it's not always available everywhere. The same kind of features. So ideally, you're suggesting that it should have a Doppler as well.
No, what I suggest is there are different purposes of my statement. So one is, see, when I'm talking of you a mobile phone based ultrasound, then I'm
Mhm.
talking of remotely or field. I'm going
Mhm.
to the field for surveys,
Yes.
or I'm doing it remotely with the office. We are
Mhm.
doing examination in the office. So you have this thing to send it to some endocrinologist pictures. For
Mhm.
initial assessment, it is fine, right?
Mhm.
But if you go for a detailed assessment and you suspect something, then you send it to a specialist ultrasonologist, because you and I are not specialists, right?
Mhm.
So then I'll send to ultrasonologist. The first screening will definitely have some idea about what it is. Then I send to specialist ultrasonologist who has a proper machine to do the Doppler as well as do aspiration cytology and everything, same setting actually. And coming to the equipment, there are many small equipments available nowadays, like just like a laptop, little bigger than laptop,
Mhm.
with all Doppler facility, everything. So I use those things for my field study when I
Mhm.
go for my got a survey in the field. So I used to take those small laptop based ultrasound, little bit thicker than that, little
Okay.
thicker than laptop. So it has a Doppler system also along with that.
Okay, that is interesting. Now, this is the TIRADS reporting and data system that you talked about. And
Yeah.
this is actually supposed to be the standard way in which any thyroid ultrasound should be reported, right?
This is standard, because see, that's give you like for example, for us to get a feeling of what it is, because I don't know how to interpret ultrasound unless I do it
Mhm.
regularly. I see it
Yeah.
every day, then I can interpret. For somebody who is not looking at regularly, so at least they will get an idea from here that
Mhm.
the cytology is given some kind of non-committal features, but TIRAD has shown most such TIRAD 4, TIRAD 5. So I take a decision. At least this nodule cannot be observed. It
Mhm.
has to be removed, right? So
Yes.
the most important thing, thyroid nodule, should I go for a expectant treatment? Shall I what advise the patient? Just
Yes.
observe or to
Yes.
operate? That's a major decision actually.
Yes.
And
I'm
if you're
coming to that.
or if you're a general physician, then you also decide, should I send this patient to a surgeon, or should I send to endocrinologist to follow it up? Even you also yourself can follow it up in this
Mhm.
patient also. And that decision is very important actually. Tomorrow it should not happen that with indeterminate cytology, I
Mhm.
am being observing this patient without taking it out for the benefit of kind of suspicion actually. So that is decision is very
So
important.
yes, I will come to the patient journey afterwards, just after we finish the assessment. Mm,
Yeah, this slide actually denotes, actually in thyroid nodule, where do you go for higher investigations? Nowadays with so many imaging thing coming up, everybody goes for MRI, CT, PET, all these things have become very, very kind of what you call again abusing the
abusing.
investigations. I must say that you don't require so much thing. There is vested interest also to do those investigations. I don't want to go in details about that. So many people come to us with so many investigations from outside, which are not necessary at all. So investigations there to help the physician surgeon to manage this patient, not that you just satisfy the industry for that. So where you do ultra CT scan, if at all you do a next investigation after the standard quadruple assessment, yeah, I'll go for a CT scan. It is done only in large goiters, or there is yeah, nodular involvement of the lymph glands. I want to see the lymph nodes,
Mhm.
large goiters. But is it how it related to the surrounding structures like the carotid artery, jugular vein, extension of the goiter, how length inside the thorax it is going. So all these things important for surgical management. Where is the trachea, how it is placed. Though in plain X-ray also you can see the trachea,
Mhm.
but it will give you very clear. But there is tracheal extension of the tumor. Sometimes cancer also you find that extension of tumor to the tracheal lumen. So all these things can be picked up by CT scan. So you have to be very clear. What do you want to get the information from by doing an advanced imaging study in that actually.
Mhm.
And I'm not going to details about what the indication of PET scan, what is the indication of
No,
other
absolutely, yeah.
test. Yeah, that's not indicated in this particular talk actually.
Okay. So, uh, FNAC. So basically, a patient's journey. Let us say how it normally. Just I'm just giving a very kind of a normal this thing. So patient goes to a doctor, has a thyroid function test done. Maybe symptomatic, may not be symptomatic, and as a part of the thyroid evaluation, may have had an ultrasound of the thyroid, or it is possible that there is a nodule, and on examination and an ultrasound was done and a nodule or multiple nodules were detected. So, Dr. Mishra, what is the kind of a journey a patient can expect? Because in terms of symptoms, will there be any big difference between someone who has, let us say, Hashimoto's hypothyroidism versus thyroid cancer? My point is, are there specific
Any
symptoms of thyroid cancer? Early thyroid cancer, not
no,
advanced.
thyroid cancer has no symptom at all, right? If at all there will be some sign, this
Mhm.
symptom occurs in the very advanced thyroid cancer, if you want that way, because I have seen patients having this goiter for many years. In India, it is very quite common. They
Yes.
are there with many years. You can see also in Africa and other
Mhm.
developing nations, actually, they don't bother about this thing. It doesn't cause any
Mhm.
symptoms. Many
Yes.
places, they think it is a decorative thing, the ornament,
I
they put
think.
some tattoo mark also. So they don't bother about that. Symptom occurs when there is a pressure symptoms,
Mhm.
right? Whether it is benign or malignant.
I
But
know.
particularly, if you ask me the question, is there any pertinent symptoms for cancer? No,
Mhm.
there is no symptoms unless there's advanced cancer, which
Mhm.
is invading to trachea, which
Mhm.
causes hemoptysis, blood comes out from the mouth,
Mhm.
or it is a cancer which is putting pressure on the esophagus,
Mhm.
or dysphagia occurs. So all these things, or there is metastasis of the cancers in the bone,
Mhm.
right? So then the patient comes with, oh, I've got a symptom in the, sorry, swelling in the head.
Mhm.
So, or they have metastasis in the spine causing paralysis. Like
Mhm.
some of the follicular cancers, the metastasis to the bone. So
Mhm.
they cause paralysis. So these are all kind of manifestations that occur. So I cannot really categorize the symptom like I've got a cough, I've got some
Mhm.
throat infection. It's not like that.
No.
Most of the thyroid nodules are asymptomatic. People
Yes.
don't bother about these things, right? Only will bother if there's a pain. Most of the thyroiditis will have a pain,
Mhm.
or something had toxic goiter. It does related to the thyroid. Toxic goiter is more
Yes.
so your answer to your question is I say that it is not. Majority of cases are no symptoms.
So, Dr. Mishra, what often happens is because in India, the report first goes to the patient. So, if I've asked a patient to do a thyroid ultrasound, now in the report they read that there is a thyroid nodule, and next they go on to to research what a thyroid nodule means, and the first thing they think of is malignancy. So by that time they set up an appointment with me, and I can explain to them what it is. They have already thought of the worst possible thing. So the important point is early thyroid cancer doesn't have any symptoms, and if it is very advanced, of course, it will rarely be undetected. So again, going back to the patient journey, so they have a ultrasound detected nodule, and you have described all the different features. So if a nodule is very small, like you said, less than 1 centimeter, does it need an FNAC if it doesn't have any of the characteristics that you mentioned in the ultrasound? Or can we wait and watch? So which are the ones we can wait
No,
and watch,
see,
and which ones need an
so
FNAC?
these are the patient that you got as I told you before that less than 1 centimeter chances of malignancy is very high. Even if there is a malignancy comes up later also,
Mhm.
it is not any harmful because less than 1 centimeter, if you should go for the low risk, high risk cancers classification, they are very good prognostic cancer up to 3 centimeters, right?
Okay.
So at the same time, many patients has a asymptomatic thyroid nodule which you don't pick up also. If you
Mm-hmm.
go to the community and do a routine survey of the ultrasound, you would find many people have a nodules. Sometimes in some of the epidemiological studies, they found 40%, 30%, like the tumors,
Yes.
thyroid gland, they have nodules. So that
Yes.
doesn't mean that we will pick up everybody and do a thyroid hormone and do a cytology examination. No,
Mhm.
it's not like that. This is circumstantial kind of evidence that you find. If somebody has come routinely diagnosed as nodules, at best you should do a ultrasound
Mhm.
and also do a cytology just to characterize the nodule. Otherwise, what happens? This patient will definitely have in the mind, oh, I have some problem here,
Yes.
and keep
Yes.
bothering that thing. So at least characterize the nodule. Even
Mhm.
if you call colloid nodule, most of them will be colloid nodule. So you can assure the patient, just
Mhm.
don't bother about this thing, but just come to follow up every 2 months, 2 years, or 3 years, and see the just assess your thyroid nodule size, right? Then you do ultrasound and see that after 3 years or so it's increasing or not. So that is one thing. Otherwise, if you don't do it, then they will have in the mind. See, for rural population, they don't bother what you have
No.
to
Yes.
do. But the issue is those people who are the guided by the empowered by Google or some of the information resources or some of these laboratory reports what they just advise them. So they will be after you. So
Mhm.
better satisfy them. Yes.
So again, one quick question is: if a thyroid nodule is less than 1 centimeter and does not have any ultrasound characteristics which are suspicious of malignancy, then when should we repeat the next ultrasound? Is it 6 months or is it less than that?
No, if it is just a simple ultrasound with a nodule of 1 centimeter or so, just leave it. If it's colloid goiter 1 centimeter, tell them come after 2 years or 3 years,
Okay.
depending on how they're approachable
Okay.
nearby or far places. They are
Okay.
safely assured actually. Even they come after if somebody can do every 2 years, it is fine.
Okay.
Relatively
So 2 years
okay.
is relative, is quite safe. We don't
Fine,
have to
yeah, yeah.
repeat an ultrasound in 6 months
No,
or
no need.
a
No,
year.
no need. No, no need.
And I think we were just discussing. We didn't. I didn't ask you for your final this thing. Does every FNAC need an ultrasound guided, or is it dependent on the
No, no,
experience
no, no, no.
of person who?
See, see, a very good question, because this is one of the questions you ask our resident also in their exams. Because see, if a ultrasound has a solid nodule and you can feel it, no issue at all. If the
Mhm.
ultrasound is a cystic ultrasound
Mhm.
nodule, right, and there is
Yes.
a mass, I showed you in one
Yes.
ultrasound,
I
one of
think I'll just
the
go back to
pictures.
that slide because you were talking
Yes,
about that one, and I
yeah.
thought that was this one.
So
This.
like we see this side in your right side of your image, it's a solid nodule, and
Yes.
it's felt in the clinical, and you can feel it, you directly hit it, right?
Mhm.
And you can push the needle straight away, it'll hit it, right? And
Mhm.
but when this is there, if you blindly do it, then you will end
Yes.
up in aspirating the colloid. So that's why you have to go for a US guided ultrasound. So we
Mhm.
hit this particular solid area, right?
Yes.
So there are some situations like intracystic papillary carcinoma. So you find those things are picked up by US guided. Then second indication is when you find multiple nodules, right? Which
Mhm.
nodule to hit? So
Yeah.
which is dominant nodule?
Yes.
And in the multinodal goiter, you'll find many nodules are cystic, some are degenerated, some are solid nodules. So you have to only hit those things. Or toxic goiter, no need of aspiration.
Mhm.
As I told you, exceptionally rare the malignant can occur there. So no need of aspiration. Straight away go for surgery of these patients. So cystic nodule, guided aspiration, multinodal goiter, right, suspect malignancy, then hit the particular nodule which is representative of those ultrasound. These two. And third thing is some of the nodules can be in a very deep location, not
Yes.
felt. They
Not
are
fair.
seen by ultrasound, but they're posteriorly located somewhere.
Mhm.
So you cannot hit it. So you hit it, you go to the normal thyroid. So if you do ultrasound guided, then you can posteriorly located nodule also you can pick up.
Okay. So after the FNAC, the tissue is, I know so this is again basically what you were talking about, which are this is the American Thyroid Association guidelines for fine needle aspiration, solid nodules more than 1 centimeters, of course, a PET detected one. And in the interest of time, Dr. Mishra, I'm just going to hurry a little bit. So again, you have already mentioned all these things when you should go for an FNAC. This is the other important thing. When should, let us say, this 6 clusters of cells, each containing 10 cells, if they don't meet this criteria, uh, what should they do? Should they repeat it right away, or they should wait, or what is usually what is recommended?
Yeah, this is the standard recommendation for cytology actually.
Mhm.
So otherwise it will be inadequate specimen, right?
Mhm.
So
Yes,
one of this difficulty they gave in reporting is inadequate specimen. Then they have to go for
yes,
repeat aspiration. So
yes.
at the initial aspiration, better you satisfy this criteria. This is the usual recommendation for FNABC of the thyroid. So
So
if it is
normally,
not,
because I
go
have
for
not seen an FNAC thyroid done. So supposing they do an aspiration, is it that they put it on a slide and check right away
they
whether
do,
we have
they
adequate
do, they do.
specimen?
Cytology lab when you send the
Mhm.
patient, they have microscope in side by side.
Yes,
They will keep on, they put the needle back and forth, keep
yes,
suctioning, then they bring it out, then put in the slide, they spread it, then they see the microscope immediately, right? Then
yes.
it's not adequate, then again go in and they keep on doing that actually.
Thank you, because otherwise the patient will have to go multiple times for
That's
inadequate
exactly.
specimen. So
Yes,
this is
yes.
basically your decision making algorithm. Am I right?
Yeah, this is my last slide. So I've just
Yeah.
put it here just to say that how to take a decision, because very important it is after the exercise of this thing. Patient has traveled to so many
Mhm.
places, got so many
Yes.
tests. Naturally, patient like to know what is next plan for this thing. I put it very simple way.
Mhm.
That is just you do the TSS, very important, and triple assessment, ultrasound, FNA. Low TSS, naturally you do a isotope scan study.
Mhm.
So then find out toxic goiters, toxic nodule, grapes, or multiple goiter. Then they treat accordingly with the
Mhm.
separate line of treatment. And for non-toxic goiters, you go to malignant straight away. You go for surgery, whatever surgery you prefer. If it is small size, go for a conservative procedure. And if it is a large size, there's a criteria for that. Low risk, high risk, all those things, very complicated algorithm for that. You decide what kind of surgery required. Essentially, it has to refer to a surgeon.
It has,
Then
yes, that is what I was
then
coming to.
next comes the ultrasound and FNA suspicious. Then
Mhm.
in that case, if it's altered thyroid nodule, the diagnostic hemithyroidectomy, as I told you, don't leave it just like that. It's indeterminate by cytology. Better to remove that particular lobe. And if it is comes up malignant, unfortunately, you have to go in again. If it is a large size, less more than 4 centimeters nodule, then you have to go in again and remove the other lobe. If it is less than 4, you can watch patient
Mhm.
for follow up. But if it is multinodular goiter, it is benign or malignant, you have to do total thyroidectomy. You have to remove the entire thyroid gland. Then other thing is ultrasound and FNA benign. Look for other indications, and usually you don't do surgery if it is a small size nodule, as I told you, or a goiter which patient is not bothered about that. Why should unnecessarily compel the
Yes.
patient to undergo surgery? She doesn't want for to be removed, right?
Mhm.
And if it is STN, solitary thyroid nodule, go for hemithyroidectomy. If it is multiple goiter, again you go for total thyroidectomy. Indications depends if it is large size, causing pressure symptoms, cosmetic appearance, all these things. You have to discuss with the patient. You have to
Discussion.
counsel the patient.
Yes.
Yeah,
So that is actually essentially more of a specialized, they need to meet a specialist. So sort of
they
like
need to be.
primary care level or an internal medicine level, someone like me would be usually ultrasound detected nodule. Then they either have to go for an FNAC, depending on the criteria we talked about. And the FNAC report will decide what the next steps are. And anyway, for the next steps, they have to meet a specialist. It's not something that most primary care doctors will not be doing the surgery anyway. So basically these are some of the this is basically how you take care of a thyroid nodule. And if you have anyone has any questions, please feel free to email me. I think this was the last slide. So Dr. Mishra, I have a few questions about, given that in India iodine deficiency is still very common, and particularly in the sub-Himalayan region, and we know that iodine deficiency is one of the problems of hypothyroidism. So, and considering that the 24-hour urine iodine test is not a very practical test, so some papers have shown that we can use a serum thyroglobulin as a sort of a surrogate measure for iodine levels. I'd like to know what your opinion is about that.
Now, my point is, why do you want to go for iodine level estimation? That's my first question to you. Why do
Okay.
you go? Which it is not a routine assessment of the
No,
patient, right?
no.
Take it. Unless it is now is considered as epidemiological investigations. Like
Yes.
I'm involved with the study of the trade
Hello. Dr. Mishra, your audio is. Hello. So while I wait for Dr. Mishra, the audio went off. Hello. So while I wait
In the
for Dr.
community. So I go
Sorry,
to
Dr.
take
Mishra, I'm
get the
very
samples
sorry.
from the urine. Part of no, none
Dr.
of third
Mishra,
pathology request.
Dr. Mishra, I'm sorry to interrupt you. I couldn't
What's
hear
the audio
anything.
problem? I don't know. I'm.
No, it's an internet connection, not your audio
Can you
device.
hear now?
Now I can hear. So will you
Can
just,
you hear now?
yes, I can hear now. Will
No,
you repeat
I
what
just
you
want
said?
to say, yeah, what I just want to say, urinary iodine estimation is part of an investigational study
Yes,
for epidemiological
yes.
research, right? It
Not
is
for
not,
individuals.
no,
It
no,
is
it is
not
not a
for,
routine
no.
thing for that, actually. Let me tell you that. We do iodine estimation study in our lab for only the samples we collect from the community, right?
Mm.
We just completed
Okay.
a research recently. In that, we collected about thousands of the samples from the school children, primary school children, and we do estimation study to find out in a particular locality what
Mm.
is happening to their trend, right? They
Yes.
may not be having any goiters, but whether
No.
they're having this urinary iodine is okay or not, or
Mhm.
they are still suffering from iodine deficiency,
Mhm.
because even if the iodized salts have been given, the iodized salts may not be quality controlled. So those things have for epidemiology actually. By
Mhm.
doing estimation of iodine, whatever method you are using, right? I'm
Mhm.
not going to ask about that.
Mhm.
What is the interpretation about that? For example, your thyrogen test, whatever surrogate marker you find, somebody has iodine deficiency. So what is the therapeutic option for this person?
Mhm.
Are you going to treat them with iodine?
Here, of course, you do get iodine tablets. So where I'll tell you where the challenge comes, because people read a lot about iodine, using iodine in, hypothyroidism. So, and I always have to remind my patients, you cannot use iodine without knowing your levels, because excessive iodine itself can cause thyroiditis. So just willy-nilly, taking some, iodine supplements because they read somewhere, that can be extremely dangerous. That is one thing, because iodine is not like, excessive levels can cause a problem. It's not like, having a water soluble multivitamin, which will, if your body doesn't need it, it'll just be a benign thing. Iodine is not as benign in those who don't have a deficiency. So that was the reason, because patients read a lot of stuff and sometimes they don't know which one is applicable to India, a country which still has a lot of iodine deficiency, versus, countries like Canada and the US, where iodine deficiency is not as common. So, yes, here we have the option of using a dried urine iodine test, which is not available in India and costs a lot. So, that was basically my point in bringing up the iodine, because the other major problem is iodine deficiency conditions are still quite common in India even today, and particularly, as a former OBGY, iodine deficiency in women planning a pregnancy or in pregnant women, that is very serious because of, mental retardation, and all those issues are still there. But there are no easy answers, because there is no simple test. You just go to the lab and get your iodine levels tested. So that was just my way. I just wanted to highlight that, what is relevant to India is it's different from what it is in many of the countries where they don't have iodine deficiency. Because a lot of people, Dr. Mishra, you probably don't meet these patients. A lot of my patients think, oh, if it is available, then I'll just do a test and find out. I don't think you
I
get that.
mean, well, it's very difficult. It's very difficult to do understand the brain of the patients, because so I can understand, but I can only say what science says. There is
Yes.
nothing therapeutic indication of iodine for any thyroid problems actually, and the measurement that you are doing iodine actually. So I don't know how accurate those tests actually. If that has been so accurate, I think you should have really followed those tests in our studies in the community. So why
Mhm.
should you really carry those samples and in -4 and keep it in the lab in -4 and do the
No, it
complicated
doesn't,
test? You
it
don't
doesn't
require.
work. So,
So one of
but
the paper we have just under process of publication. Once it comes out, I'll send you the paper.
thank you.
So we have done some community studies. So I think we do iodine only for the community studies,
Community level.
and our medical colleagues they do, and we have a special interest.
Mhm.
Our community public health research is based on the iodine deficiency analysis. Now we have added ultrasound in addition to the iodine urinary iodine estimation, because many of those we study the volume. They were
Mhm.
not having any nodules. This is
Right.
not part of the discussion of your topic today, but
Yeah.
we can talk about that
Yes.
another sitting. That
Yes.
what are the implication of iodine deficiency currently and all those problems that occur due to iodine deficiency, like mental retardation and other things. So nowadays, these are very, very important for understanding micronutrition and its impact on the health. There are
Yes.
many zinc, iodine, so many other compounds are there. They're very, very important for human health. And
Mhm.
now many things have been thought of in India. We had to fortification of the milk with diet with iodine plus another calcium and other things. They are all things are going on
Things
actually
are going
in
on.
parallel. Uh, uh, but iodine itself is a very complicated thing actually.
Very
Till now,
complicated.
many things are not answered actually. What is the impact of these epidemiological studies? Should you go for therapy intervention? Like in China, they used to give injections, and as you rightly said, little bit of more iodine also causes thyroiditis. So
Mhm.
you have to be very, very careful
Yes.
regarding therapeutic iodine administration.
Thank you, Dr. Mishra. So, basically, what Dr. Mishra you're saying is for people who don't understand what an epidemiological study is. This is basically finding out what is the population level of iodine. Now, that does not mean that if the population level is showing low, it doesn't mean I will know what my level is if I'm living in that area. But if the general level is at a lower level than the rest of the normal, then highly likely that my level could be low. But again, it is so personalized because I might be eating something that is richer in iodine or maybe better quality salt. And of course, in countries like Canada, people sometimes eat seaweed and things like that just to add the iodine. So that is one thing. The other thing is, as a former OBGY, there is something we used to call a prenatal multivitamin. So it's very important for about 150 microgram of iodine to be there in the prenatal vitamins. However, the requirement in the pregnancy is about 250 microgram. So if you are taking, this is my message to pregnant women or women who are contemplating pregnancy, make sure that if you are taking a multivitamin, it does contain at least 150 microgram of iodine before pregnancy, and your requirement after pregnancy is higher. And again, no simple answers, everything you need to discuss with your doctor what applies to you. If you are listening to this is not medical advice. So thank you, Dr. Mishra, that was excellent. You gave a lot of insight to people who are, as you rightly said, thyroid is dealt with by practically everybody. I mean, obstetrician, endocrinologist, internal medicine, family doctor, endocrine surgeons, everybody takes care of the thyroid. Thank you very much. Okay, bye now.
Welcome. Bye. Thank you.